When we look, I'm a plumber of the heart and as an interventional cardiologist, so we do a cath and we look at the big pipes. And if the big pipes are open, we say, okay, nothing's wrong with your heart. But that's only 20% of the blood flow to the heart. The rest of the 80% of the blood flow is small arteries that we don't see on a routine cardiac catheterization. So how do we see them? We do testing for microvascular disease. Does it matter? Yes, it does. Because if you have microvascular dysfunction, if that 80% of the blood flow is not working correctly, it increases the risk of stroke, increases the risk of heart attack, increases the risk of dementia, increases the risk of renal failure. So it is not something we want to take lightly or ignore.
Hey everyone, this is Jonathan Marx from GoToHealth. I hope you're having a wonderful day. Another important topic today, we always try to do this. This is evidence-based. We're going to be talking about heart attack in women and how it differs from heart attack in men. The symptoms, the risk factors, the treatments that women get versus what men get. And what you're going to learn about is a surprising lack of information about heart attacks in women. Why? Because the predominant number of heart attack studies that have been done have focused on heart attacks in men. And we're now understanding the differences between men and women and heart attacks, and more research needs to be done. So what's really important as a woman is to advocate for yourself with your doctor if you think you're having heart problems. In the show today, we're going to be talking about warning signs, about symptoms, and about what you can do to keep your heart healthy. Our guest today is Nishtha Sareen, MD, MPH. She's an interventional cardiologist with extensive professional and clinical experience delivering high-quality, evidence-based care to patients suffering from complex or chronic heart conditions and diseases. She is board certified in general, interventional, endovascular, echocardiography, and nuclear cardiology. She maintains board certification as well in internal medicine. Dr. Sareen is the medical director of the Women's Cardiovascular Services for Ascension Tennessee. Before we get to Dr. Sareen, a request. Visit our website at gotohealthmedia.com and subscribe so you can see all our shows. And if you're listening to us on Apple's podcast or YouTube, please give us a thumbs up or a 5-star review so that the message gets out to more people. Thanks in advance for sharing. Welcome to the show, Dr. Nishtha Sareen. How are you today?
I'm doing well. Thanks for having me, Jonathan.
Good. I'm really looking forward to this conversation about heart attack in women. What's the difference in heart attack symptoms in women versus men? Please tell us.
Heart attack symptoms can be very different when it comes to women versus men. Men will have the typical crushing chest pain going to the jaw, shoulder, arm. Women can have more subtle symptoms, just some shortness of breath. I wasn't feeling right. I was feeling nauseous, dizziness, back pain. The reason for that also is that we have popularized chest pain, as we call it, the Hollywood chest pain symptoms, based upon studies where more than 90% of participants were men. So truly, we have not studied heart attack symptoms in women.
And is that still true today, that we haven't studied heart attack symptoms in women?
In 2026 as well, we lack representation of women in clinical trials. It still continues to be around 85% of men.
Wow. You're bringing up a really important point, which is the importance of when we have evidence-based medicine, that we need to make sure that we've got participants in these clinical trials that really represent the population. And what you're telling me is that there still have not been enough women represented in clinical trials related to heart attack. That's just incredible to me.
It is. And honestly, if you think about it, the magnitude of it, we do not represent 50% of our population in the studies we are doing. And which is true not only for how we diagnose it, it's also true for the treatments that we give right now for heart disease.
I'm just puzzled by this because it seems that there would be enough incentive to have women included in these trials. Why has that not happened yet?
It is a very complex problem. It has to do with enrollment of women. We have to start to improve advocacy for women so that they understand that heart disease is their biggest killer. What's staggering is that even today in 2026, 44% of women, which is almost 1 in 2 women, do not realize that heart attack is their biggest killer.
Mm.
It is 6 times more common than breast cancer. It is more common than all cancers combined, but women don't understand that. It is the biggest killer of women during maternity, in pregnant women too. So it's not also that it's not a big killer in young women. So it's advocacy, it's awareness, and also the passion of our physician group, our clinician group, our researchers to make sure women are enrolled in trials.
Good. I'm so glad we're discussing this today. So tell me, what are the risk factors in women that are different for heart attack compared with men?
So that's a great question because there are traditional risk factors that we talk about, like diabetes, hypertension, high cholesterol. Now, are they the same in men and women? No. A woman with diabetes is at much higher risk of heart attack and stroke compared to a man with diabetes with the same disease state. So, one thing to understand is that the traditional risk factors do not manifest the same way in men and women. And then we come to the non traditional risk factors or conditions that affect women predominantly. For instance, pregnancy, having eclampsia during pregnancy, preeclampsia during pregnancy, having early menopause increases the heart attack risk in women by almost 25%. Having 3 or more children, which we call multiparity, increases the heart attack risk in women by almost 20%. So these are risk factors that we don't talk about routinely and should be focusing on.
Good. I'm so glad we're having this discussion today. Is there a difference in outcomes when women versus men get treated with a heart attack?
Again, a great question. As you can imagine, if we are delivering care based upon studies that have predominantly been done in men, how can we expect outcomes to be good in women or as good as we have in our male counterparts? So if you look through any study in cardiology and interventional cardiology, you will see that women tend to do worse compared to men after a heart attack, even in 2026.
And why is that? What's going on here?
Because the treatments that we deliver, the way we diagnose them, the way we treat them, is not based upon studies that are specific to women. They are based upon studies. We know those treatments work in men, but we haven't done a good job to study women and know if truly those treatments work in women.
So is it that we don't know what treatments work well, or is it just that doctors aren't informed of what the best treatments are for women? Do we really not know even today?
Even today, we make the treatment we deliver is predominantly based upon the evidence that we have. And it is the best treatment that we know about as physicians. But is it as good in women as it is in men? No, we do not have that information.
So what do we do to change this? How's this going to change, doctor?
This needs to change from the grassroots level. It needs more representation of women in clinical trials. We have to study them. And this might mean, honestly, in real terms, to start from square one. But if that's what it takes, I think it needs to be done.
Okay, boy. So I know that you can specialize in what's something called microvascular dysfunction. Can you explain what that is and what relevance that has to heart health in women?
Absolutely. So we have women, and actually 40% of men as well are in that population where you would have chest pains, chest pressure going to the jaw, shoulder, arm, exertional shortness of breath, exertion and chest pain. And you've had stress tests, you've had heart catheterization, and everybody keeps coming back and saying, nothing's wrong with your heart, but you keep having that pain and pressure every time you exert yourself. And sometimes even similar to symptoms of heart attack. These patients keep coming back to the emergency department. Now we know that there is a condition called microvascular dysfunction, which means that when we look, I'm a plumber of the heart and as an interventional cardiologist, so we do a cath and we look at the big pipes. And if the big pipes are open, we say, okay, nothing's wrong with your heart. But that's only 20% of the blood flow to the heart. The rest of the 80% of the blood flow is small arteries that we don't see on a routine cardiac catheterization. So how do we see them? We do testing for microvascular disease. Does it matter? Yes, it does. Because if you have microvascular dysfunction, if that 80% of the blood flow is not working correctly, it increases the risk of stroke, increases the risk of heart attack, increases the risk of dementia, increases the risk of renal failure. So it is not something we want to take lightly or ignore.
So what tests should we be getting to test for microvascular dysfunction so that we know that we have it?
So it depends upon the physician's discretion, risk factors, of course, which is the best course. There are non-invasive tests and there are invasive tests. What does non-invasive mean? It's specialized PET scans that can be done, looking at blood flow in the artery at rest and at stress, which gives us a fairly good idea in patients as to whether or not they have microvascular dysfunction. Also, we do in the heart catheterization lab a more dedicated testing. That's the gold standard for high-risk patients where the suspicion is pretty high. And we test not only for one element of microvascular disease, we also test for something called Prinzmetal angina or Vasospastic angina. So it is two big options. Which one is better for you depends upon your clinical presentation.
You talked a few minutes ago about advocacy. How can a patient advocate for themselves to get this kind of testing if they're coming back? I guess the warning sign is you keep coming back with heart pain or chest pains. How can we advocate for ourselves to get this kind of tests?
I think even asking the question, when you ask the question, hopefully we will be in a place where the patient will not have to ask the question and the physician will ask the question themselves.
Ideally.
But until we get there, all of us have to work together towards it. And the first starting step, and we see a lot of patients, Jonathan, in our program who've come to us because they believe there's something wrong and they just are not getting the answers. So asking the question, even bringing up the word microvascular disease can click it in the mind of the person who's seeing it. Because a lot of times, we are used to treating patients the way we've been trained. And it has not been incorporated in our curriculum as physicians to look at female-specific conditions, female-predominant conditions such as microvascular disease, which are just starting to evolve.
Okay, boy, I'm certainly learning a lot here today on this. I'm glad we're having this discussion. What are some take-home points you would recommend for audiences to prevent heart attack? Are there warning signs that women should be aware of, before they have serious symptoms? How should they know that they're at risk for heart attack? What are some warning signs?
So I usually tell all my patients it's a triangle. There are three things you have to remember. First is make sure you're eating healthy. Make sure your plate is as colorful as possible. And the color should be vegetables, not as many fruits. Vegetables are healthier than fruits. If you're doing fruits, look at their glycemic index. Make sure you're eating the fruits that have lower glycemic index, which is particularly berries. You can't go wrong with that. So that's rule number one. Rule number two is exercising. We have to be sure we're doing the amount of exercising that is recommended by ACC and EHA guidelines, which is we should be exercising 150 minutes a week at moderate intensity. What does that mean? It could be 15 workouts, 10 minutes each, if you're really busy. Or it could be 30 minutes, 5 days a week. But the workout starts when you cannot speak in full sentences. So that is how you measure the moderate intensity. So just walking does not count. It's got to be an intensity where you can't speak in full sentences. And the third important part of the triangle is to know your numbers. Know your BMI. BMI is a calculation which takes into consideration your weight and your height. And it's a simple online calculation. We want it to be between 18.5 to 24.9. So if your BMI is in that range, you're looking good. If it's abnormal, it is a red sign. It's a red flag. And I would say you need to get consultation. Make sure you know your cholesterol numbers. Make sure you know your blood pressure numbers. Those are the important three aspects that help us make sure we are staying healthy.
And what would you say most people are at? Or, are most people at 24.9, or do we really have, there's so much obesity in the American society. What are people's BMI at, if not at 24.9?
The most of our patients do fall in higher BMI levels. If it's more than 25, we usually have dietitian work with them and we put it into exercise regimen. But also one thing to remember is that this BMI index is not very specific. because it takes into consideration your weight. It's not distinguishing between muscle mass and true adipose tissue mass.
Mm-hmm.
So there are, although we have data that if your BMI is abnormal, we do treat you, but we take that into consideration as well, clinically and in practical aspect as to is this mainly muscle mass or is this adipose tissue? So there's additional elements we use. For instance, waist circumference is something we look at as well, neck circumference. So we take that into consideration as well when we're analyzing BMI.
Got it. Now you have a website. It's called the BIAyourself.com. And let me spell that for people. It's BIA, BIAyourself.com. What's on the website and what do you hope to gain from people coming to the website and visiting?
Thanks, Jonathan. So, one of the things I realized very quickly was that what we do in the walls of our hospitals and our clinics has to get to the patients out there. And how do we get there? It is by getting into the community, making them aware of their heart, just like you are doing, right? To make them aware of their heart attack risk, talk about symptoms. And Bia Yourself is a website that tries to achieve that by providing our patient community credible information from physicians. So we do have podcasts which are from physicians and have credible information once every other month, talking about topics that are really important that we should be paying attention to. There is also a book that we had compiled, and the book focuses on heart disease risks in women, also written by physicians.
Good. That's great. So it's BIAyourself.com, BIA yourself.com. Where's the name Bia come from?
So Bia, it's so interesting that you asked that. She was a goddess, a Greek goddess, who has a very important role in Greek mythology, but she was lost and nobody knows about her, though she had a significant role during the War of Titans. So, when I was reading through about Bia, it felt like the story of every woman who's out there, who struggles through everything. She's the sky for everybody, but gets forgotten very easily. And that's how this name originated.
Okay. Well, we certainly don't want that. And I'm certainly glad you've come on the show to help us learn about heart health for women. That's been so great. Is there any question that I didn't ask yet or a final message you'd like to leave with people today, Doctor?
Jonathan, I think you covered most of it. The one thing I'd like to say is that if heart health in women will ever get anywhere, if it will ever improve, it will not be without advocacy of our male counterparts. People like you, Jonathan, who are promoting it. Whether it's a husband, it's a brother, it's a father, we have to pause and make sure that women in our home, at our home, are taken care of. They're taking care of themselves. Because we have done really well with heart health in men, and our women have contributed significantly for us to get there. So I think it's our chance now to make sure we all work together towards the same goal.
Good. So glad you're here bringing us this message, Doctor. Thank you for your expertise and your advocacy. It's been so enlightening.
Thank you, Jonathan. It's my pleasure. Nice
Good.
talking to you.
Yes, you too. We've been talking with Dr. Nishtha Sareen, MD and MPH. She's an interventional cardiologist with extensive professional and clinical experience delivering high-quality, evidence-based care, we like that, to patients suffering from complex or chronic heart conditions and diseases. She is board certified in general, interventional, endovascular, echocardiography, and nuclear cardiology. I think I got all that right. She maintains board certification in addition in internal medicine. Dr. Sareen is the medical director of Women's Cardiovascular Services for Ascension, Tennessee. And tell us about the clinic there, Doctor.
Of course. So Ascension has the mission of serving the poor and bringing care to them with reverence and dignity, which is very much in line with the mission of being able to serve our underserved female population. At Ascension St. Thomas in Tennessee, we have 3 women heart clinic locations, one of which is in Nashville, the other one is in Franklin, and the third one is in Rutherford, providing homogeneous, evidence-based care to women at each location.
Great. Thank you so much. God bless you in your work. Thank you for doing what you're doing. And we will get this word out to as many people as possible to keep women's hearts healthy. Again, doctor's website is biayourself.com. It's BIA yourself.com. Thanks again for being with us, doctor.
Thank you, Jonathan. Thanks for what you're doing.
So thank you, everybody, for watching. You can visit our website and learn more. See all our shows at GoToHealthMedia.com. If you're watching us on YouTube or listening to us on podcast, if you give us a thumbs up or a 5-star review, that helps us get the word out to more people. Thanks so much. This has been Jonathan Marx with Go to Health. And as we say at the end of every show, go to health. God bless. We'll see you again next time. Take care. Thank you for tuning in today to Go to Health. You are one of almost 10,000 people per day who enjoy the evidence-based health information offered by our guest health experts. You can watch us on our website and YouTube and listen to us on 8 podcast networks. Be sure to join Jonathan Marx in our upcoming shows each week. If you like our show, please share this episode with your friends and colleagues. You can subscribe to the show, join our email list, send us feedback, browse through the online store, and view our library of over 150 shows at GoToHealthMedia.com. See you next time, and remember to elevate your life with Go to Health.